Good morning all. I am presenting my paper titled Effect of Topical Corticosteroids and Non-Steroidal Anti-Inflammatory Drugs to Control Post-Operative Inflammation Following Uneventful Phacoemulsification, a retrospective study in Tertiary Care Center in North Kerala. So post-operative inflammation after cataract surgery is of paramount concern for both patients and surgeons. Topical corticosteroids were commonly used, but they can cause increased IOP, it can delay the wound healing, and can increase the risk of infections. So ketorolac is a cyclooxygenase inhibitor which is available for ophthalmic use. Given orally, intramuscularly, or intravenously, the analgesic properties is comparable to that of narcotics. So when used topically, it shows efficacy in treating cystoid macular edema, reducing post-op inflammation and relieving ocular itching associated with seasonal allergic conjunctivitis. But on prolonged use, they can cause transient burning, stinging, conjunctival hyperemia, superficial punctate keratitis, corneal infiltrates, epithelial defects, etc. So the aim of my study was to compare the efficacy of topical ketorolac 0.4% and topical dexamethasone 0.1% to control post-op inflammation, conjunctival hyperemia, corneal edema, and changes in intraocular pressure after uneventful phacoemulsification. People aged more than 40 years of age with no sex predilection who underwent uneventful phacoemulsification and were willing to comply with post-op medications were included in my study. And patients with secondary cause of cataract like post-inflammation, steroid-induced traumatic cataract, history of intraoperative complications like hyphema, vitreous loss, iritis, uveitis, history of non-sensitivity to the above medications, history of topical systemic inhaled steroids within 14 days prior to surgery, history of pre-existing diseases like glaucoma, corneal disease, inflammatory eye disease, severe dry eye were excluded from my study. Coming to data collection analysis, it was a retrospective observational study, and the data was obtained from previous records of 110 patients who underwent uneventful phacoemulsification and who were used topical ketorolac and topical dexamethasone between 2020 and 2023. So all patients underwent a thorough ophthalmological examination preoperatively. Post-operative evaluation included uncorrected and best-corrected visual acuity, conjunctival hyperemia evaluated by slit lamp examination. Intraocular pressure assessment was by non-contact tonometry, corneal edema and anterior chamber reaction by slit lamp biomicroscopy. Follow-up examination was done at day 1, 1 week and 1 month post-op. Descriptive statistical tools like mean, standard deviation, absolute numbers and percentage were used. Inferential statistical tools like t-test and Mann-Whitney U-test were used. Coming to the result, in my first group, majority 51.9% patients were between 51 to 60 years of age and 40.7 patients were between 61 to 70 years of age, and my steroid group 32.1% patients were between 51 to 60 years of age and 51.8% patients were between 61 to 70 years of age. Visual acuity preoperatively majority, that is 88.9% and 82.1% patients respectively in both the groups were having a visual acuity of 636 to 624. At post-op 1 month, majority 96.1% patient in my first group and 85.7% patient in my second group had a best corrected visual acuity between 6.9 to 6.6. Coming to intraocular pressure, preoperatively 79.6% patients in my first group and 82.1% patients in my second group were having an intraocular pressure between 16 to 20. At post-op 1 month, majority 92.6% patients in my first group were having no rise in intraocular pressure, whereas 60.7% patients in my steroid group were having a rise in IOP. So this was statistically significant as dexamethasone group showed more IOP spikes. Conjunctival hyperemia also showed significant improvement after the initiation of the respective drops, but there was no statistical significance between both the groups. Coming to anterior chamber cells, at post-op day 7, 57.4% patient were having grade 2 cells in my first group and 14.3% patients were having grade 2 cells in my second group. This was statistically significant as my steroid group showed more efficacy in controlling anterior chamber cells compared to ketorolac group. Anterior chamber flare and corneal edema also showed significant improvement, but there was no statistical significance between both the groups. So to conclude, ketorolac 0.4% can be a good alternative to dexamethasone 0.1% in controlling conjunctival hyperemia after an uneventful phacoemulsification. However, dexamethasone group had a better control of anterior chamber reaction as compared to ketorolac group, but it was associated with higher IOP spikes. Coming to the limitations of my study, small sample size and was a retrospective study design. These are my references. Thank you.
Can you go back? So have you put any any other studies which,
Haven't put the discussions like.
yeah, because that is missing. Because I don't, isn't this study already done?
Several studies
Would
have
have
been
been
done
done.
in this category, like lots and lots of studies. So this is something where the discussion is very important.
Due to lack of time, I.
So
Basically, you need to have a slide on the first slide, correct? The topic and the presenter name. Second slide, no conflict of interest, no financial interest. Third slide should always be the aim of the study or introduction. Either introduction.
if you look at all the slides, there is a lot of text in all the slides. Okay? You should reduce the text on the slides. Since this is a PowerPoint, like Sir said, maximum 7 sentences. And you should not be reading the whole thing. You should have just word, word, word. If you want to make it smart art, okay. In PowerPoint, you can make it smart art. Then you put one word followed by the next word, and then link them, and you say postoperative inflammation of cataract surgery, and that is enough. Rest of it you will say is quite important or something like that. You will mention. You just have only those 5 words there, okay. And next step, topical corticosteroids, enough. And then you say topical corticosteroids. So you reduce the text on the page, okay. And the graphs are pushing into the tables. So all those things you have to change. And there are some you see the NSAIDs. It would be good if all of them are capitals. NSAID is a it's in full form of this thing, right? So you have to put it as capitals. Millimeter mercury, you have to put H as capital. So all those small things, they create an impression. So make sure those things are also done correctly. And yeah, discussion should be there. Can you just go to the next slide? Yeah. So methodology. So what was the post-op dosing? Ketorolac?
A QID.
QID. So that was either QID ketorolac or QID dexamethasone.
Dexamethasone.
Okay, you're comparing exactly the same dosage. So ketorolac has some potential corneal side effects. Okay, so anything you encountered, any corneal epithelial damage or any sloughing or anything?
Nothing.
Yeah, so all those will come in part of your
Yes.
literature's review. If you look ketorolac post-op or even cornea, you will see that it is not used because it has potential devastating corneal melting side effect also. So that is also there. And any reason why ketorolac was chosen, why nepafanac was chosen, or anything like that?
No, before we have already done a study on epafinac, so
Okay,
escape.
so that also you can compare in the discussion. Okay, so those are things which everybody would want to know. Which is better? Why ketorolac? Why nepafanac? One better than the other? Those things will be important to know.
A good study, Rohitha, but as everyone is telling, too crowded slides. You could have made the male female ratio, everything you have included, no, in the single, in the single graph, and also the tables also. So why did you do a retrospective study? You could have done a prospective, no?
Yes.
So this protocol has been followed in your institute since how long? Only NSAIDs in one group and only steroid. That is the protocol you are following, no?
Yes.
Antibiotic and steroids for one group and the other one
antibiotics and KT for the other group.
KT. So you have pulled out the charts where this was given, only ketorolac given to one group, or you have not randomized, no? You have done an retrospective study. So since how long you have been giving only NSAIDs?
Since 2020.
2020 onwards, you are not giving steroids at all
Yes.
to a group of patients, to an uneventful clear corneal phacosurgery. What is any reason for that?
No, we just want to study. So
You just
No.
wanted to study.
So you yourself said that IOP spikes are there with dexamethasone. So those are the things which you have to say. Yes, ma'am, we wanted to avoid we had a few patients with IOP spikes, so we wanted to study we can do with NSAIDs which will prevent the IOP spikes.
So is there a complaints difference? Because the what we are afraid of is the patients are not putting the drops. So now once daily Nepafenac and all are coming to improve the complaints. So ketorolac, what is the dosage you have advised?
QID dosing.
QID dose.
QID.
Okay. And steroid group?
QID.
QID 4321 you are telling. Not the combination.
No, ma'am.
So antibiotic for how many weeks you are giving?
We are using the combination antibiotics with steroids.
Antibiotics, Dexa, antibiotics combination you are giving.
Yes, ma'am.
Same antibiotic or different antibiotic?
Same antibiotic.
Same antibiotic for 4 weeks you are giving.
Yes, ma'am.
Okay. And then any rebound iritis happening to the ketorolac group alone?
No, nothing. We didn't find any patients with rebound.
They didn't come back.
One patient with KT group, they at post of 1 week, 1 month, they presented with grade 4 cells and hypopion and all. So we stopped and we started that patient with steroids and he improved.
Hypopion. So you
Hypopion.
have ruled out ENDOF also.
Yes, ma'am.
So it was an iritis alone.
It was yes, ma'am.
At the first post-op review, how was the cells and plan in that patient?
At post-op 1 week, that person had grade 3 cells and moderate flare.
At that point, nobody added steroids.
No.
So those are very significant things. So not only significant findings, those are protocols. If a patient presents at 1 week with severe iritis, will you change the medication? That also becomes part of the protocol because then the patient is switching the group. Or whether you will continue with it for 1 month, no matter what. Those are things which have to be defined in the methodology. Okay. Or that will be considered as a treatment failure.
Yes.
You should mention that these are specific instances where the methodology will be followed and you will mention that this happened, so this had to be, patient had to be changed, so there was a dropout from this study. All those have to be mentioned.
So what is the, any lubricants you are added to the post-op regimen?
No, madam.
No. So since you are using 4 times, sometimes ocular surface problems can arise. Any patient complaining of stinging or did they stop the medications or anything in your sample?
Patients which are dexamethasone or ketorolac.
DEXA.
Yeah, depending on the preservative, and if you back preservative is good for the penetration. Benzalkonium chloride is not good for your cornea, but it is good for the penetration of the drug. So majority of the NSAIDs use BAK, but that is why we are reducing the dose. The once daily higher concentration preparations are now available. Instead of 4 times, you can give only once, so that you can improve the complaints as well as the ocular surface toxicity. Anyway, good study. You can continue with this and let us know the result.
This is something which can be easily continued. So you have a lot of patients. Your sample size was how much?
110.
Yeah. Why only 110? Because I am sure you have more patients than that who are following this regimen. Correct? Why did you pick 110?
The minimum sample size was 53 in each group. So
Okay. Okay, so don't take the minimum sample size. Minimum sample size is a minimum requirement. Okay. So if you have more data, you get more data, you get better results and a more impressive study. I am sure you have much more than that. No, how many approximately you might be having past 2 years? You are which year post?
second year.
Yeah. So since you joined, you are sure that 110 is just a fraction, right? So by the time you finish your PG, you will be continuing this study and you will be publishing the big study on this. No, this is a pilot study for you now. Correct? Is this your thesis?
No.
Okay. So this is your pilot study, side study, pilot study. Once you finish your PG, you will be collecting data for 3 years or more and you will be publishing the big study, right? Yeah. So now at that point, you should remember to make all the changes according to the suggestions, and look at. So you are putting only ketorolac. No, there is no other nepafanac
No, only
arm or
kit.
anything else. Okay, you can consider starting another arm like that, and make sure that you take all the patient complications, like patient getting iritis, all those you have to note those things. Okay. Post-op 1 week, how many patients developed grade 3 cells or more, grade 2 cells or more? Those things have to be mentioned, and you should have a protocol. What will be done if that happens? Will you add a steroid at that point, or will you continue on that for 3 more weeks until patient comes at 4 weeks? At that point, patient might come with something which looks like an endophthalmitis. So hypopaean and all that is very scary for a ophthalmologist. So just make sure that you have a modified protocol to take care of those eventualities. And by the time you finish your PG, you publish that big study. Okay.
Surgeries, no, like cataract, and 1 month only the follow up, no. So you can include more patients. Anyway, for 1 month they will come for the follow up. There is no lost follow up in the study. So that you increase the sample size. Anyway, you are doing a retrospective study and following this protocol since 4 years, I think, 3 years, no. So you can pull out more charts and do a more impressive study. Best of luck.